Hi, and welcome to the December 11th, 2013 St Vincent's Hospital Plastic and Reconstructive Surgery Journal Club. My name is Damien Rohrich, and this is Dr. Rhys van der Rijt, who's the current unaccredited registrar of St Vincent's. So, as usual, we did 4 papers, and the first paper we did today was the 5-step neck lift, integrating anatomy with clinical practice to optimise results. This was by Stuzin, Rohrich, from Dallas, Texas, and it was published in the August 2013 issue of the journal. So, Rhys, what was this paper about in a nutshell? What is this 5-step technique?
So, this 5-step technique is 5 steps that are based on certain previous anatomical cadaveric studies. They start by mentioning the first step, which is a facial neck skin undermining, a wide medial and lateral undermining and joining in the midline with straight facelift scissors, leaving 3 millimeters of fat under the dermis. The second step is a submental access and direct excision of fat and, if necessary, midline platysmal plication. Yeah,
so they say that the midline platysmal plication is important and to sort of minimise the fat resection if you possibly can. But essentially the step 2 is the midline work, and then step 3 is creating a platysmal window, which is basically elevating a small area of platysma, which is beneath the angle of the mandible in an anatomically safe location with respect to branches of the facial nerve, and then anchoring that up to the mastoid fascia over the great auricular nerve. The 4th step is to further free up the mandibular ligament, or the mandibular septum as he refers to it in the paper. And then the final step
is SMAS and skin redraping through either SMASectomy or SMAS stacking, which is what they recommended.
So what did you think about this paper, Rhys?
So I thought it was a great systematic approach to neck lift surgery. They assess patients at different steps and modify or do what needs to be done at different steps, which provides a tailored approach for the patient. And I guess any description or any paper that marries an anatomical study with a surgical technique is certainly a sound thing.
And they had very good before and after. They presented 2 cases, and both were extremely impressive in terms of the improvement gain in the neck contour. All right, so that was the first paper. The second paper, high pressure injection injuries of the hand, current treatment concepts. So this was a review paper from a PRS earlier in 2013, doing a comprehensive literature review of high pressure injuries, injection injuries to the hand. And so, Rhys, in a nutshell, what were the conclusions of this review paper?
Well, the conclusions are that high pressure injection injuries are serious and they need to be dealt with promptly in a timely fashion and correctly.
So they were saying within 6 hours, 6 hours being a key time point, and making the point that the actual injury and the extent of the dissemination of the injected material is often far greater than the physical examination may suggest. And they were saying that the typical patient is a male in the mid-30s, and the injury is to the index fingertip of the non-dominant hand, so they've injected something there. What else was important in this paper, did you think?
I guess a wide surgical debridement of necrotic tissues should be performed under general anaesthesia when necessary. If mild to moderate class of injuries, it can be treated conservatively. So I guess just the analysis of the patient and the appropriate treatment accordingly.
Okay, the next paper we did was the concept and method of closed reduction internal fixation, a new approach for the treatment of simple zygoma fractures, by Uda et al., and this is from the November 2013 PRS, and there was a comment by Dr. Ellis. And so what is this closed reduction internal fixation technique they're talking about?
So basically, it's a minimally invasive technique that is used for simple zygoma fractures. The patients that were selected, they didn't have any preoperative orbital or visual issues and didn't have any shearing at the ZF portion. But basically, a stab incision or an incision is made to 2 centimetres to lateral canthus.
Yeah.
And the fracture is reduced. Essentially, a KY is used to maintain reduction, and a screw is inserted over the K wire as a guide wire, a second KY, sorry, and the screw is essentially removed around 4 to 6 weeks.
Yeah. I mean, the really good things about this study was they obviously had the pre-op CT, but they also did monitoring CTs in order to assess reduction and the maintenance of reduction or relapse with time, showing that in fact there was hardly any relapse. It was 0.12 millimetres of inferior movement and 0.47 millimetres of posterior movement. So basically absolutely minimal reduction. It's a good technique. The operative time was very fast, and obviously the soft tissue morbidity is minimal when one compares it with various approaches to the infraorbital rim, whether it's a subciliary or a mid-lid incision. They're much higher risk of ectropion and soft tissue ptosis of the midfacial soft tissues. Was there anything else about this paper?
No, I don't think so.
That's basically it?
Yeah.
It's all good. Okay, the final paper for 2013. Options for configuring the scapular free flap in maxillary, mandibular and calvarial reconstruction. This is from the head and neck unit at Royal Prince Alfred Hospital here in Sydney, and this was a retrospective case series of 41 patients who had various scapular free flaps between 2006 and 2012. So in a nutshell, what was this paper talking about, Reece?
So this paper described the use of the scapular free flap, the different options of parts of bone of the scapular or subscapular system and soft tissues that can be used to reconstruct these complex defects of the maxilla, mandible and calvaria. In the paper,
there
were 41 patients and 42 free flaps in total. They sort of ascertained or measured complications, dental rehabilitation outcomes, indications for surgery and flap types.
Yeah, I thought this was really well done. They've got good discussion points about the use of scapular free flaps for maxillary, mandibular and calvarial reconstruction, and given examples of each. There is a good use of bone, which is going to give you a better reconstruction for those 3 areas, with the emphasis on aiming for dental restoration where possible. And the anatomy was very good. They addressed the issue of how they position the patient, because that's certainly one of the reasons why scapular flaps aren't very popular. Generally, people don't like repositioning the patient, where they use an inflatable beanbag. They have access only to the scapular tip from a lateral sort of view, and are able to do the ablative surgery and then the reconstructive surgery without repositioning the patient. The anatomy is very good and their results are excellent. Is there anything else about this paper?
No.
No? Can't think of anything either. All right, that is it. So that's it for another Plastic Surgery Journal Club. For those of you who are there, I hope you enjoyed it. And for those of you watching now, thank you for listening. Okay, bye.
Thank you.